Good afternoon, everyone. Good afternoon and welcome to the 17th Annual Littlefield Leadership Lecture and to the University of Wisconsin-Madison School of Nursing. It's a pleasure to see all of you here. My name's Susan Zahner. I'm an Associate Dean for Academic Affairs. It's my honor to represent the school and our planning committee for this event and welcoming you. We have had over 300 practice leaders, students, faculty from around the state register for our event and are participating today in this room, in an overflow room here in the building, and also live streaming from this room today. So I welcome all of you. The Littlefield Lecture honors the 16-year contribution of Dean Vivian Littlefield. Dean Emerita Littlefield is here today, and so I'd like her to stand up so that we can acknowledge her. Professor Littlefield served as dean from 1984 to 1999, and then went on to serve as the National Chair of Nursing for the American Red Cross. She received her PhD from the University of Denver in Colorado. She's an expert in nursing care delivery, alternative approaches to care, and their impact on patient outcomes and on women's health. Dr. Littlefield continues to be active with the American Nurses Association, Sigma Theta Tau International, and is a fellow in the American Academy of Nursing. Dr. Littlefield is recognized as a scholar of leadership and of mentoring, and that's the purpose and the impetus behind this leadership lecture series. Her work has shaped nursing practice and policy over many years. So we thank you again, Dr. Littlefield, for your support, and we're very pleased that you're here with us today. It's also my pleasure today to introduce Dean and Professor Linda Scott. Dean Scott was named the 8th Dean of the UW-Madison School of Nursing this past July 2016. Scott has a distinguished career of academic leadership. She served at the University of Illinois Chicago College of Nursing as Associate Dean for Academic Affairs and Director of Graduate Studies, PhD Studies, and Urban Health. From 2009 to 2012, she served as an Associate Dean for Graduate Programs at the Kirchhoff College of Nursing at Grand Valley State in Allendale, Michigan. Dean Scott earned her PhD from the University of Michigan, her master's degree from Grand Valley State University, and her undergraduate degree from Michigan State University. We're hoping to convert her to a badger while she's here. Dean Scott's program of research focuses on the impact of fatigue and sleep deprivation on both nurses and their patients, and her work has had significant impact on national policy related to the prevention of nurse fatigue and the protection of patient safety. Dr. Scott is a fellow and a board member of the American Academy of Nursing. She's a board member for the International Network of Doctoral Education in Nursing and is an editorial board member for the journal Advances in Nursing Doctoral Education and Research. We are very pleased that she's joined us here at UW-Madison, and so please welcome her to the podium.
Well, thank you, Dr. Zahner. It is indeed a pleasure to be here to welcome all of you to our Littlefield Leadership Lecture Series. And don't worry, Dr. Zahner, I've already been converted on Wisconsin. Before I introduce our speaker today, I'd like to take a moment to thank all of the individuals who have helped to make this event a success. First, I'd like to acknowledge 3 sponsors for today's event and ask representatives from each to stand. Our platform sponsor, UW Health, our silver sponsor, Gunderson Health System, and our bronze sponsor, UW Oshkosh. Please join me in thanking them for their generous support. The Littlefield Lecture Series is also sustained through the long-standing support and generosity of the Friends of Littlefield. Would all of the Friends of Littlefield please stand? And I know you're out there, I saw you. Again, I'd like to thank you for your support over the years. And I would also like to acknowledge and thank the staff and faculty who have worked hard behind the scenes to prepare for this day. I think you'll enjoy not only our lecture series, but also the wonderful reception that's planned for you after Dr. Trautman finishes her presentation. So thank you, faculty and staff. So, our featured speaker for today's Littlefield Lecture Series is Dr. Deborah Trautman. Dr. Trautman is the president and CEO of the American Association of Colleges of Nursing, and she has served in this capacity since 2014. As the national voice for baccalaureate and graduate nursing education, AACN serves the public's interest by setting standards, providing resources, and developing the leadership capacity of membership schools to advance nursing education, research, and practice. In addition to her role at AACN, Dr. Trautman has held numerous clinical and administrative positions at the University of Pittsburgh Medical Center and at Johns Hopkins, where she served as the executive director for the Center for Health Policy and Healthcare Transformation. She has also served as a Robert Wood Johnson Foundation Health Policy Fellow, where she worked for Nancy Pelosi, then Speaker of the House of Representatives in 2007-2008. Dr. Trautman is a member of several professional societies and serves on a number of high-profile boards and advisory groups, including the Department of Veterans Affairs, Special Medical Advisory Group, and the National Academies of Science Global Forum, Envisioning the Future of Health Professional Education. As you can see, Dr. Trautman brings her wealth of experience in health policy, nursing education, clinical care, hospital administration to our Littlefield Lecture Series. Please join me in welcoming her to the podium. Dr. Trautman.
Thank you so much. Thank you. Thank you. It is an honor to be with you today. I would like to thank Dean Scott, Dean Emeritus Littlefield, the distinguished academic and practice leaders who are here today, faculty, students, and I understand there may be some other health professionals with us. I'm thrilled to be with you today. I would like to begin my remarks first by telling some of you a bit more about the American Association of Colleges of Nursing, because you may be unfamiliar. But then I am going to transition my remarks to speak about where I think there's opportunity and tremendous challenge as we try to move forward both in improving health and healthcare in this nation and globally, as well as our challenges in higher education. And I'm going to share some data that I hope you will find helpful. We will have time at the end for questions as well. So, and the American Association of Colleges of Nursing, as you heard, is baccalaureate and graduate schools of nursing. Our membership is 790 schools, and you may ask, is this 100% of all the schools that could be a member? And the answer is no, but I'm working very hard as others because I believe it should be. And we are working with schools so that we can continue to provide support and resources that will help our schools, our deans, and our faculty. And I'll talk more about that. But it represents over 457,000 students, 18,000 full-time faculty, and 4,000 full and part-time faculty. So it started years ago, actually in the 1960s. The association was initially founded to support deans, but we have grown in support of a mission and providing, again, value and services to all of the constituents that are part of our academic institutions. Our fundamental focus has been throughout our history on improving the quality of nursing care, but we believe that today what this means is that we need to re-envision the traditional roles that we've had, and we know that our practice partners are doing the same. We need to work together to think about how we can change and evolve ourselves so that we are meeting the needs of a changing population. We also know that education matters. We must create a highly educated nursing workforce. Many of you may be familiar, a report that came out of the Milken Foundation a few years ago, it showed that with just adding 1 year of educational attainment, college education, to a region, the GDP in that region improved by 17.4%. So we know that education matters not only for the profession, for safe, quality patient care, but indeed there's a return on investment for all of society. And we believe that we have an opportunity, although our profession has a history of making a difference, we believe that we have an opportunity to do even more. All of us in nursing, but not alone, with other health professions as well. So right when I started at AACN, there was a bold new strategic plan. The only error, I think, in this slide is that we're fooling ourselves if this work is going to be accomplished in 2 years. But I will now go on to tell you what the work is. And that as an association, and there are, many of you may know, over 100 nursing associations. Our focus, of course, is academic nursing. We want to be a driving force helping support innovation and excellence in academic nursing. We need to be a leading partner in advancing improvements in health, healthcare, and as I said before, higher education. And we also must do more to advance diversity and inclusivity, both within the profession and we believe even within our association. And then I think this last one is one of the most exciting and probably one of the most yet to be discovered opportunity, and that is to be an authoritative source of information curation. Increasingly more for all of us, we receive information from so many different sources, and it is really a challenge to think about how we are as informed as we can be to be making the best decisions. And we are not, of course, the sole information source, but AACN has a history of providing very rich data, for example, to understand what's happening with enrollments, graduations, with what's happening across our schools, but we want to work with others to make sure that we're providing information that is helpful not only about our membership, but some of what the changes are that are happening in healthcare and higher education. And at the end of the day, our AACN used to have a vision statement for the association and then one for the profession. I think we had the wisdom to roll those together. And our vision statement is that nurses everywhere, in every practice setting, are leading efforts to transform not only the delivery system, but to improve health. As a collective voice, as you already heard, our focus is also nursing education, research, and working with our practice partners. So we were very clear on our values, but I believe these are values that when I talk to others across the country that are shared by many. Leadership for all of us is very important at all levels. I had the opportunity prior to my time at AACN of teaching a leadership course, and this was not so long ago, and I was surprised to learn that many, or at least more than I think it should have been, thought of leadership by title, leadership by a position. And in fact, as a profession, we have a responsibility to lead regardless of what the titles are. And these are times that certainly require our contribution. And innovation, collaboration, nurses have been collaborating for quite some time, but we believe very important. Integrity, of course. As you all know, nurses have always consistently in the Gallup poll been rated as one of the most trusted professions. Now, unfortunately, though, when you ask the public about who is, not who should be, but who is most influential in shaping health reform and health policy, it is not nursing. And we need to recognize that, one, that is the perception, and then help to change that perception and show where there's opportunity that we have. And we have already, for example, made a difference. Despite what you may like or dislike about the Affordable Care Act, there are over 40 provisions in the law that are nursing specific, and those provisions were included because of the work of nurse scientists and nurse leaders in policy. So while it can be very challenging, as a profession, we have demonstrated both in the past and I believe in the future how our work and policy will make a difference. And I passed on agility. Sorry, I should not have sped up on that, especially because as I've come to learn more about all of our worlds, I had a recent conversation with the president of a university, and he said universities weren't designed to be innovative and weren't designed to be agile, but yet we need to think about how we do that. So that was unintentional, passing that up. Most of you are probably familiar, but I would remind you that in the late 2000s, it was Dr. Don Berwick, who was at the Institute for Healthcare Improvement, IHI, who coined what's become known as the triple aim, which is that what is our work in this nation, perhaps beyond, but most certainly in this nation, what should it be about for now and the foreseeable future? And it's improving the experience of care, the health of populations, and demonstrating our value. Some would add that there's a fourth quadruple aim for health professions, and that is that we should demonstrate and do a better job of taking care of ourselves. So you know that care is transitioning, and you know that we're moving more towards team-based. We want and continue to advance nurses practicing at their highest level, interprofessional. I was first offended when I heard person-centered, patient-centered. I said, I've been a nurse for forever. Of course we are. But in fact, we aren't. It is more about the system, and so we're working to drive changes. And I would tell you that I believe each of us have had individual experiences of excellence encountering the healthcare delivery system. We've also probably had individual experiences that are not up with excellence, or where we would want them to be. But we are, I think, really thinking differently about what it means to be person-centered and community-focused, and I'm excited about those opportunities. These charts were, with permission, borrowed from Dr. Mark McClellan, who recently gave a presentation at the National Academy of Science. And why I put these in here is that I think it helps to remind us what are we trying to fix in this nation. And I would tell you that I believe in 2016, the good news is we have recognition that in this country we could be doing a better job promoting health and delivering health care. We may not have agreement on how we should do it, but we have consensus, which wasn't always the case in the United States. But we have, as this slide can show you, it's been estimated, excess costs approaching $750 billion, of which unnecessary services, one example, has been calculated to be at 210 billion services. We can't afford to continue in this light. And as a nation, if we simply were dealing with the fact that we're an aging population, our current system isn't designed to give us the best outcomes. We need and know we must do more. This next graph, I want to show you this because some folks will say, well, yes, the United States does spend more than most any other industrialized country, and yet we don't realize better outcomes, and so that's not acceptable. But they say, overall, we're not spending collectively more than other countries. But why I put this slide up here and what I think is telling about it is the blue bar. The blue bar is what we're spending once you're sick. The red bar is what countries are spending in some individuals' view of preventing, so some of the social services or the support that can go around. So what many are saying in the country is that while we want to bring down the blue bar, what should we be doing, if anything, to raise the red bar? And that's more of the conversation that's happening again at a national level. And while not consensus, I think another huge challenge that's different for those of you that are starting to practice nursing now compared to when I did years ago is that income-related disparities are increasing. There are significant differences based on income with respect to life expectancy and other health-related issues. We have, when you look at the United States compared to other countries with respect to income inequality, we are considered at the 30th percentile, which means that 70% of the countries are doing better than we are with leveling the degree of disparity in income inequality. And many of you may know, but there's a host of sequelae that go along with that. One of the changes that has happened in my lifetime as a health professional is that the growing gap, it used to be the rich and the poor. The growing gap now is the middle class and the extremely wealthy. And in the long term, that's not projected to be a healthy recipe for the nation. So I also include, and you all are very familiar, but we no longer can look at the importance of health and healthcare in a vacuum, and that the social determinants of health are increasingly more important. This is just one slide that captures the many dimensions of social determinants of health, but economic stability is important. Neighborhoods and physical environment, education, food, and the community and social context. And I'm from Maryland originally. Many of you may know. Maryland has been for quite some time unusual with respect to healthcare payments in that it's an all-payer system. Maryland pays hospitals, essentially, I'll oversimplify it, but alike, and negotiates these costs. But the state decided that we still did not yet have the properly aligned incentives. So hospitals are bearing the burden of some policy changes because the state's asking the hospital to figure out some of this other with respect to social determinants of health, and it's not quite how the hospital and health systems have been structured. So it's a colleague of mine who is extraordinary, and they're doing great work. He said to me recently, it's like going whitewater rafting. You're not given a boat, and you're expected to land on the other side, and just about how do we do that? And so I think that as I've talked before, and some of you who know me, I'm extremely optimistic about our future and the work that we're doing right now, but I am not naive. This is not all, this isn't easy work. Some of this is hard lifts. The aligning incentives, we've got many misaligned incentives, but if we're going to drive better health and health care, we will continue to see more action along aligning incentives. All of you are familiar. This is the cover for the Future of Nursing IOM report. Some of the lessons that I and others have gleaned from it, but I think for all of us, again, we cannot overemphasize the importance of leadership. And when I think about leadership, I've been, in my mind, thinking about how are we informed by evidence? And while there isn't necessarily evidence for every problem and or the solution, increasingly more reliance on data and providing data to others will be important. But we also need stories, personal stories that connect, and that will help us advance our initiatives. But we need to be innovative. I think we need to continue to develop ideas, courageously make some decisions, create change, and then I like the one of pushing boundaries. And even though I think that's something that is good for us to do, there are days where I am hesitant to push the boundaries. But I believe that we must challenge ourselves, and not just nursing, all health professions and how we do this. So I want to take a moment to cover some of the information very briefly. In the Institute of Medicine's report, the recommendation to expand and transform nursing education, we are making progress, and thanks to many of our practice leaders for the emphasis on baccalaureate education as well as graduate education, but we're not going to achieve the goal of doubling by 2020 that was stated in the report. So there's been great work that's been happening with respect to academic progression and also with our approaches to providing support so that we can indeed advance. A key message, of course, is we are, as a profession, lifelong learners. That's not news, but I think increasingly more critical for us. And back to that agile, nimble, being able to move quickly, I understand from many of my colleagues, changing a curriculum isn't something that can happen overnight, but and some would argue, nor should it. But I believe that we have to increasingly find ways to be more responsive. We are indeed an aging population, and as I said, if nothing else changed, that would still present challenges. I did want to share with you that enrollment in RN to BSN programs, there's a 69% increase overall in the enrollments. And I wanted to share, I wanted to do some comparison just so you could appreciate. So on this slide, we have had since 2010, 88 new entry BSN programs. We've seen a growth in accelerated programs. We've seen a growth in enrollment in DMP programs. It's tripled in nursing. And in PhD programs, it's increased by 10%. So how does that compare, you may ask, to other data with respect to doctoral and graduate education? So I went to the national data, there's a report, the National Data of Graduate Enrollments, and that's from the Council of Graduate Studies. Since 1986, in looking at the period of 2005 till 2015, it's only the second time in our nation's history more than 2 million individuals were applicants for graduate education. And of those applicants, there were 1.78 million enrolled. When you look at what's happening with respect to doctoral education, there is increasing diversity, increasing representation of those who are underrepresented. There is also a change that most doctoral education in many years in the past was predominantly male. Now, for the first time, and this is all doctoral education, for master's degree education, 58% are women, and for doctoral education, 51% are women. So those numbers are changing. When we look at a doctoral degree, the production is what the term they use in the report, so it's not good enough just to be in the program. Are we getting out on the other side? And across all doctoral programs, the range has been reported as less than 1% up to 13.7%. But I want you to see that the Doctor of Nursing practice programs has increased by 19%. So granted, it's a growing doctoral degree, and we have had more widespread acceptance and adoption of the degree. This is just some growth in some of the other programs. I will point out, so there's a disturbing number here on red with respect to PhD programs. And many of my colleagues have asked, this particular number, and it's for the year 2015 to 2016, was the result of one online program closing. But that program had pretty wide reach. However, there had been some criticism about the quality of the program, and I'm not here to pick on any particular program, but I think, as you all would, that it's not just the quantity, the growth we want to see in these programs, but by most certainly assuring that we continue to have the highest level of quality in our educational programs. This will show you, again, some of the growth. I'll go through these, and these will be available for you more later. But just to have some visualization of the growth, this is enrollments and graduations in DNP programs, enrollments and graduations in PhD and Doctor of Nursing Science programs, and then both DNP and PhD programs. We've combined that together. So I would like to shift now, moving away a little bit from that data and focusing more explicitly on where I and others believe that we can and should be leading. And in addition to what we need to do most certainly for healthcare in higher education, I would say to you that I believe in this nation, regardless of what happens in the current political environment with the election, there will be continued focus on the quality of higher education. And all of us in higher education, who's ever sitting in the White House, there was going to be continued interest in us in academia demonstrating the value. Improving access for education is important to our political leaders, but also important to many of our community leaders. And again, I believe we all think we should be doing a better job promoting a healthier nation. I'm from Maryland, one of the richest states. We have still one of the highest percentages of obesity. We have then chronic diseases that go along with that, with obesity and the sequela. So we, again, as nurses, should be change agents. I am a big fan, many of you may know, Dr. Mary Wakefield. She's an extraordinary nursing leader. She was she's currently the Acting Deputy Secretary for Health and Human Services, which is one of the largest governmental organizations trying to drive improvements in health and healthcare, and has been for quite some time. At a pre-confirmation hearing, and she is well respected by both Republicans and Democrats. Nurses have been able to cut across the aisle in some ways where others have not. But what she said is at this one particular hearing, but I think it resonates well for all of us to think about in our future. It is indeed in a nurse's DNA, collaboration. I don't know if it's genetic, we learn it early on, but that collaboration and what we bring to the table with our innate ability to think about collaboration is going to be very important, that we focus on problems fully and we do work to the extent we can quickly. So she has said it's really in a nurse's DNA to work collaboratively. This was in response to, she was asked how she was going to do if she were if she were full-time, not the acting deputy, but confirmed as the deputy secretary, how would she work across the aisle? And I agree with her that for nursing, our focus on collaboration has been a foundation of the profession. This slide, you all, I'm preaching more to the choir, I would believe, but you know that nurses have made contributions with respect to research leadership, patient care leadership, and workforce development. But again, despite our best efforts, much more yet to be done. We need to instill the interest in discovery, the importance of discovery with students at all levels. We need to think about what that means in helping others outside of the profession understand the contributions that we make. So I want to take a moment to talk about the changing demographics. I've already mentioned this briefly, but we are an aging society. So as you can see, by 2030, there will be about 72.1 million older persons in the United States. That will represent 19% of the population. That is, this is higher than it has been in the past. And currently, in March of 2013, many of you may be aware, that was the month that was the turning point where the births in March of 2013, sorry, that's a hard one to get out with a cold. It was the first time ever that they were majority minority births. And as this bullet point shows you, currently 54% of citizens under the age of 1 in the United States come from racial and ethnic minorities. And the term, again, minority is being requested by many that we replace with underrepresented. But at some point, clearly when we're in the majority, that's not underrepresented. But we need to, again, our society is changing. You all know that there's also a desire for the profession to reflect the changing demographics of society. And then chronicity is indeed a problem for all of us, but pediatric as well as adult populations. So I want to take another moment to share a little bit more data. I was fascinated. This report just recently came out from the Chronicle of Higher Education, and I'm not sure how many of you are familiar with it, but it had some very interesting data points and comments about what the future of higher education looks like. So I just captured a few here, but one of them, as you can see, is that there will be a smaller proportion of college students that were the traditional age, right out of high school. And in fact, you may know this, but high school students are declining. And the two areas expected to see the greatest decline are, in fact, the areas that have had the most in the past, and that's the Northeast and Midwest. And we're expecting to see a greater growth in the South. So those dynamics are going to change, and they're going to create a further supply and demand mismatch with students, and we're going to think about how we in higher education then adjust and make changes accordingly. Current data and knowledge that we have, most students still, although we do have global students and we have international students, most students in the United States attend an academic institution that's with 100 to 250 mile radius of their home. And that also is expected to change, but it's some of the current information. Excuse me, there's a fly up here with me. The next, I just want to talk very briefly that we can't dismiss also the importance of regulatory work. That regulatory barriers exist now that we've been in some states successful in addressing with respect to scope of practice, but we still, again, have much more work to do. And student loans is another area where we need to think about what the impact of regulation is and how we can work with policymakers to begin to alleviate some of the burdens that have occurred as an unintended consequence of some of the regulations. Many of you may have read this book, College Unbound, but it essentially tells us that it's not going to be the way it always was. And this school in particular is a fabulous example of how we're changing. The opportunity for active learning, the simulation area that you have, it is very advanced, and I think we will continue to see these kinds of changes and improvements happen across all health professions education. Gaming is believed to be on the horizon, but there are many in higher education who say that not yet do they think gaming is going to immediately take over, but that there already are instances now where apps are created to help interprofessional students learn, and I think we will see more of that on the horizon as well. I'd like to take a moment, and many of you are familiar with competency-based education. I recently was at a national meeting again of many health professions, and the general consensus is while we're making progress, much more to be done there. We're just really, some would say, a toe in the water of our work with respect to competency-based education. But the belief is that as we become more proficient in advancing competency-based education, it can help us further individualize learning experiences and the attainment of competencies for students. So I want to take one other moment to speak about with leadership in nursing education. And nurses have been, I believe, a leader in interprofessional education and practice. But again, I would say we have a distance yet to travel. Before my time at American Association of Colleges of Nursing, there were the founding associations for the Interprofessional Education Collaborative were pharmacy, medicine, dentistry, nursing, and osteopathic medicine and public health. Those 6 associations, I believe, AACN being one of them, came together with an idea somewhat before its time, but worked on developing competencies. They particularly stayed away from scope of practice or volatile issues, but they didn't do it because they thought they weren't important. But they wanted to be sure that we could work on what are those areas that we can collectively agree on and what is important with respect to interprofessional education. There have been, many faculty institutes that have been held, but what we're learning is that yet not enough widespread adoption and challenges within universities to advancing. You heard earlier I was honored to be a leader at a health policy center at Hopkins. I thought for sure we could do a health policy 101 for dental, medical, and public health students, and we couldn't make it happen in my tenure there because our schedules were different and we couldn't bring people together. So it seems like a simple problem to fix, and I learned that it was not. But there are increasing opportunities, as you know, to bring together students, and that when students learn together, they gain earlier an appreciation for the contributions of the other health professions. So we also, and I can defer some of this, of course, to my practice leaders, some of whom are in the front and the back, but with respect to new and emerging models of patient care. There isn't a magic bullet, there isn't a special sauce, but there is going to be increasingly more opportunity for us to think about how do we build a more accountable system. Many would argue that we still don't have a system. What are the opportunities for nursing? Again, like it or dislike it in the Affordable Care Act, in particular many nurse scientists, but one of them, Dr. Mary Naylor, some of her work around care coordination set the foundation for some really important provisions that were set forth in the law. Nurse-managed health centers, the same. There's an actual section in the law that supports the advancement of nurse practice, nurse-managed health centers. And then, of course, as you know, the increasingly importance of focusing and moving out into the community. So again, thinking about preparing educators to lead, I believe that when we think about some of these challenges, we have to, as this report says, we've got to focus on our leadership-related competencies, and again, at all levels. I know I've said that previously. I think that there's not, of course, one universal strategy or approach. Leadership development courses, most certainly. Many of you are aware there's an initiative that is to advance getting nurses on boards. And while I think that's a laudable initiative, I've shared with some that it's insufficient. This isn't a matter of we have tremendous demand and we just aren't finding the opportunities to match nurses to these openings. We need to do more as a profession in helping others understand the value that our profession brings by sitting on their boards. And so I'm looking forward to, there have been many activities within the association community to try and advance the opportunity for nurses to have this kind of leadership, offering governance and strategic planning to the Fortune 500 companies, to others outside of healthcare, to insurance companies. And we're seeing more opportunities and starting to capture. And we need to be prepared. You know, it's not simply good enough to create a seat at a table. We need to be making contributions when we're at that table. You heard that I was a health policy fellow. I'll take one moment to share a quick story. There were 4 nurses in my fellowship, unprecedented. We were honored to be 4 nurses. We were all, the 8 of us, my fellow group, attending a, at the time, Institute of Medicine conference. And some of our other health profession colleagues were going up to the microphone, in my opinion, giving a speech, not really asking a question, but needing to be heard, and were heard. And one of our colleagues, a former fellow, came up to the 4 nurses at the end of the session, and she said, "I'm disappointed in the 4 of you. Not one of you got up to the microphone to say something." And one of my colleagues said, "We don't need to do that. We know." Anyway, we weren't being arrogant, but the point really hit home to me. We didn't feel that we needed to make a contribution to the conversation. And in fact, she reminded us, by choosing to be silent, we lost an opportunity for people to understand what the profession does. And so that stays in my head, and I don't know you like I. There may be times where you think, I don't really want to weigh in here, but I think the more we can do that and share our opportunities to communicate and offer our thoughts with respect to some of the changes that go on, that it will be very important, and that we should not be silent as a profession. You have a great example here already in this state, and most certainly at this university with respect to academic practice partnerships, but we believe still opportunity to do more. So I want to come into some specifics that AACN recently worked on. But before I do, I want to make just a couple more comments with respect to a preferred future. And I had a slide that I meant to include it. I left off 2 of them, actually. One is that I think for a preferred future, in particular, for advancing the contributions of our profession, we need to maximize one of our strategies, which is a unified voice. There are over 100 nursing associations. 62 of them are now part of a nursing community, and I believe that we need to continue to advance that unified voice around certain issues. It happened during healthcare reform. A document was prepared by the nursing community, and many looked to that document for guidance. I also, despite the fact that we might wonder what we could learn at all from presidents of the United States, I'm a health policy PhD person, so bear with me, but there was a great book that was published several years ago, but it's called The Heart of Power. And it was looking at 75 years of presidential leadership with respect to health policy in our nation. And the final chapter is the only one that when I was teaching my health policy students, I said, that's the only one I really want you to read. The others, depending on your level of interest. But the final chapter summarizes lessons learned. When our country was successful, again, only with presidents, but successful or failed with respect to advancing policies that we thought would improve health or health care. And these were the lessons learned, and I think they're important for us as a profession. Do you have passion? Can you move with speed? Do you have a plan? Are you willing to overrule advisors? There are some times where there's an idea we want to move forward, and it's not yet well accepted. Are we willing to go public and create momentum? Can we be part of and deploy a talented team? And are we willing to lose? And losing is sometimes perhaps the hardest. I don't know about you all, but I find being willing to lose a little bit challenging, but we need to. So I'm going to quickly go through these as we have 10 minutes. And I want to be sure that we have time, and there are only a few more slides. We do have an aspirational view for academic nursing. AACN has looked at what our current state is and talked with colleagues within academia, university leadership, our practice partners, and we believe that we need to move from the current state to this future state, where you can see I've captured some of the highlights. There's a report, I have a picture of it coming up next that I will show you. And this report is one source of information. It is not the sole source and it is not exhaustive, but we attempted to be collaborative, working again with university leadership and others, and had the assistance of the Manat Health Consulting Group to gather data through interviews interviews, through a summit that we held, and through actually a couple other processes of convening focus groups, et cetera, to get a sense of where did we think as a nation we could go. I'm pleased to report this is the bad news across the country, not in all schools, of course, but we're not positioned as a partner in healthcare transformation. We're still yet often not at the table. Many leaders, institutional leaders across the system, though, health and higher education, see this as a missed opportunity for alignment. The devil's going to be in the detail, working out, well, what does this mean? But there is agreement that we should be doing more, and that there is an enhanced role, and that the enhanced role could be good for all of nursing. The report has 6 major recommendations, and the one that all of these are important, but I would talk again about the importance of our role in advocacy. We don't all have to like policy, but we all, every day in our work, are advocates for patients and the families that they serve. And so we need to think about how we continue to strengthen our contribution to advocacy, helping policymakers understand the magnitude of a problem, helping policymakers understand potential solutions. I shared with some earlier, so I'll share with all of you. I'm not naive. A quote in my PhD program in one of my best health policy theory books, and I actually like the health policy theory, but in the inside of the book, Kingdom Streams, if anybody's familiar, I had a used book in pencil, so I've still not found the source of this quote. But so I'm studying health policy. This is a policy theory course, and the quote is, "Politicians use research and data much like a drunk uses a lamppost for support rather than illumination." And I would share with you that as disappointing as that is, I believe indeed it is fact. But then I say, okay, fine, then who needs this supporting information? So we need a targeted strategy to make sure that our information is getting into the right hands. There are strategies in the report, this one report, which I'm pleased to report, are going to have a convening at the American Association of Colleges of Nursing October meeting, where, to my knowledge, the first time at an annual meeting, our practice partners, some of them are joining us. And we're going to talk about this report and other initiatives and strategies that we can come together and I think then on certain things and achieve higher results. So again, a commitment to transformation and evolving. Someone said to me, well, the schools of nursing aren't going to change. Oh, no one's immune from change in this report. And I thank the leadership that started first as a grassroots conversation with some of our deans that were connected to academic health centers. But those recommendations on those pillars, they apply to all of us, whether we're connected to an academic health center or not. So we now want to do some more work working with others to say, well, if we're realizing a stronger advocacy approach for the profession, what's changed? What does that look like, as one example? So the strategies, and again, these are available, but for deans in particular, some of the primary recommendations to enhance clinical practice opportunities for clinically focused faculty, that is very valuable and important. To engage with health system CNO, CEOs, and again, your campus is an example of how that's already occurred, but it's not occurring across the country. There are places where we're strangers, and that just will not continue to suffice. And that I think, the opportunities around workforce development, I had a chance for some conversation with others at lunch today, but still so much more to do. And not to do it in a silo, looking only at nursing, looking only at medicine. So will health system execs, again, thinking about ways to integrate the School of Nursing and collectively partnering so that what can we do together to enhance primary care, to enhance the opportunities to build a clinical network. Also, advancing, it's a touchy one, but professional billing is one that I think, we need to think about how we can move that agenda forward. What does it look like? And it looks different, most likely, in our different, because we have different practices across the states. But there are some common ground that we could think about our activity in being more purposeful about advancing some of the professional billing opportunities for nursing. Also looking at certification requirements, but we were having a conversation at dinner last evening, and I learned, and it's not an unusual story, where we were having trouble with research and academia working together because we were requiring some certifications and credentials that really might not have made the most sense. So does the faculty member need to have ACLS to work in the health system? Maybe yes, maybe no. But I think that we have to examine our own past practices and where we can identify where we have barriers. So the summary report is here on the end. A couple parting thoughts that I want to leave with you. While I believe without doubt that there's tremendous challenge and some difficulties ahead, I am confident our profession is a profession that has made a difference throughout the course of time. Florence Nightingale brought the profession to a state very reputable, very well respected, very early on a nursing leader who understood the importance of bringing data to bear on problems and then examining that data to see how effective we were. So we have a rich tradition, but if we want to be more influential in improving health and healthcare in this nation, we need to work from a variety of different perspectives. Thank you. With respect to how we're making sure that we are not only patient-person centered, but we're also thinking about how we're evolving higher education so that we're meeting the needs of a changing student population as well. I have a slide that I didn't put on because I wasn't sure where you all would be with this, but a very dear friend of mine is a humanitarian aid reliever, but he's also a self-taught photographer. He has a photograph that I absolutely love. He took it on safari, and it's a photograph of two zebras. And I wish I would have put it in, but I'll describe it for you. And the zebras they're standing, but they're resting their heads on the back of the other. And I said to my colleague, I said, well, why are they doing that? And he said, well, you may not know, but he said in the wild, often if the zebras lie down, they can be vulnerable prey. So I'm sharing this with you for two reasons. One, a nursing student asked me a while ago, are you saying we're vulnerable prey? No, I'm not. I mean, we could be, but that's not my point. My point is that we must support each other. And I think that if we can do that and increasingly do that more effectively as a profession, it will position us well to be making these kind of changes that we need. And there's not a perfect roadmap. The other final statement that I will leave you with, the Robert Wood Johnson Foundation for quite some time used to use it as a tagline. And it's actually an African proverb, unknown source. But I like it, and I think it applies to where we are today. And that is, it says, if you want to go fast, go alone. But if you want to go far, go together. I think we have to go together as a profession. I most certainly think we have to go together as we advance our interprofessional work. And I believe that the world, and certainly our nation, will be a better place because of it. So I thank you for your attention, and it's been a wonderful opportunity to join you, and welcome questions at this time, or comments, concerns, or perhaps topics that I did not mention that you have interest. Thank you.
Thank you very much, Dr. Trautman. That was great. And now I'd like to welcome anyone in the audience to ask a question of Dr. Trautman. We have a couple people with microphones who will help us project your voice. So please, just stand up and let us know that you have a question. I thought maybe this might happen. So, great. Go ahead.
Hello, my name is Ilsa May. I'm the Director of Admissions and Advising in the undergraduate program here. And so I work with a lot of undergraduate students, and I see a lot of their wonderful faces here. If you all want to raise your hand. Undergrad, BSN students, yeah.
Right.
So the question that I had has to do with allowing them to build leadership skills, and if there's any ideas or advice you have for them, because right now especially they're trying to build foundational skills and knowledge, and probably the thought of taking on additional things and building leadership skills might be a little bit overwhelming. So what kind of advice do you have for them to kind of start building that experience, or what they could expose themselves to now while they're still in this kind of academic and learning context.
Great. Well, thank you. A couple comments that I would make about with respect to building leadership skills. And I want to say also, I'm pleased to see so many of you here. And I know that when you're standing up here giving the lecture, you are going to talk about how we have indeed moved forward and made some significant improvements in some of what sometimes seems like an intractable problem in some areas with respect to healthcare. I think with leadership, a couple key thoughts come to mind for me, but I'm sure there are many others. But some of the key ones I would say is first and foremost that we recognize we're lifelong learners and that leadership is something that we learn. John F. Kennedy had a quote that he used in his inaugural speech, and that was that leadership and learning are indispensable to each other. I think we must keep that in mind. I also think that it's extremely important, excuse me, my cold is getting to me here, extremely important to have mentors. And I was asked earlier about mentors. I think we need to seek them out, and I think they should not always look like us, act like us, or think like us. I think that we should have diversity in those who are our mentors, and learning from others. And not only seek out a mentor, but I believe it's our responsibility to be a mentor. And I also think with respect to interprofessional, I can tell you that as a part of my onboarding at the American Association of Colleges of Nursing, the IPEC principals, those 6 schools of medicine, public health that I mentioned earlier, the CEOs of those organizations were extraordinarily helpful to me and volunteered that assistance. And that, again, by us helping one of us succeed, it helps all of us succeed. And then I think we have to learn from our failures. If we haven't failed, and no, I'm not saying that we want to lose, but we're going to have some failures and stumbles along the way. But how do we learn from those? And then with respect to leadership, where you are right now, I would ask you to craft your elevator speeches, a few of them. Build a few of your elevator speeches. What's the value of the profession? How has our profession made a contribution to improving health and healthcare? And have your 3 to 5 sentences that you are able to share in a variety of forums. We don't think about that as much with respect to our messaging. When I was a health policy fellow, one of the lessons we had was make a point, have 3 points, and say them 3 times. I'm not going to say these 3 times, but one of my takeaways from that experience was if we want to strengthen influence and impact, I believe that it needs to be done through evidence. One, what is the evidence to bear on whatever the situation is? But evidence alone is insufficient. We have to build relationships, and who should we build those with besides whom we already have relationships? And then our communications. We need to be sure that we're speaking in a language that is well and clearly understood by others. And we sometimes speak in our own language, and that's okay amongst ourselves, but we need to think about that when we're working with others. So those are some of the suggestions I would have for leadership development, and be prepared for this extraordinary profession to take you on a journey that I can say, at least for myself, I did not anticipate how rich, how rewarding, sometimes how challenging it was going to be. And so I wish you the very best. Thank you. Another question?
Hi, my name is Kira Ahmed Yahya. I'm a DNP student here at Wisconsin. My question is, my understanding of the AACN's position on entry-level degree would be a baccalaureate degree as the minimum degree. What is the AACN doing to promote that?
Yes, thank you. Very good question. Well, we're not working alone. I mean, we're working in partnership with others in academia as well as other associations. There was a project many of you may be familiar with that was funded by the Robert Wood Johnson Foundation called Academic Progression in Nursing, and it brought together nursing leaders in practice, academia. It also brought to the Center to Champion Nursing was a part of it. This is one example. We worked with those associations and those leaders, and still are. There were 5 models that came out of that funded work. The funding for that initiative is going to stop, but we can't stop our work there, so we need to disseminate those models. We need to, AACN has not taken a position yet. I don't know if the board will, but has not yet on a preferred model. But right now, the current thinking is that there isn't a one-size-fits-all. It really depends on a variety of characteristics within a particular environment. I thank our practice colleagues. I believe that advancing baccalaureate education has come not only from the science that we've provided that demonstrates that the education matters, but by the embracement that our practice leaders have had in the importance. So those are some of the areas we're looking at now. So the essentials are, in essence, the standards we have essentials for baccalaureate, graduate, and doctoral education, and we are revisiting those essentials to assure that they are current and have what we believe is most important with respect to advancing. Thank you. Good question.
Good afternoon.
Hi.
Thank you for your lectures. Very good. I share your passion with policy. My name is Pam Goodman, and I've had experience working with areas in poverty, and you mentioned the growing wage inequality. And I'm just wondering if there are opportunities that are being sought to look at how we address poverty and the relationships to health. As I kind of reflect back on the areas where I've been practicing as a previous administrator, there seems to be a significant disconnect in regard to how we address those issues in regards to nursing. Again, kind of going back to what you're saying in regard to policy, education. And I have to say I've been fairly disappointed in how we as nurses are adequately prepared to have good conversations to advocate on behalf of people in lower socioeconomic statuses. And just wondering what might be happening at the national level.
Yes, very good question. And I don't profess to have the answer to it, but I would share some of what I think is happening. I think because of our increasing focus on social determinants of health in our education programs, we are widening the knowledge base and the understanding of future and current nursing professions about the importance. I think that nursing is not alone in its perhaps limited progress and or understanding about the importance and the effect of poverty. I also think this is an area where we're seeing some extraordinary interprofessional initiatives with, for some examples, schools of nursing, medicine, and public health, dentistry, pharmacy, working on and trying to address a very challenging problem. I also think there's work happening across the country with respect to the nurses and partnering with working in the criminal justice system. It was eye-opening. I was an emergency department nurse for 15 years, and I had the opportunity when I was in Baltimore City to participate in an interprofessional group our focus was looking at what we could do to eradicate the deaths that occurred as a part of domestic violence. And we brought together leaders in the city, in the state actually, leaders that were in the criminal justice system, parole and probation, health care, not the usual cast of characters to come and sit at a table. And I can tell you again, as sophisticated and as smart as I thought I was, it was eye-opening to learn about some of the challenges within the system. But I think increasingly more opportunities. I'm from and have a home in Baltimore, and I was extremely saddened with the riot situation that happened not so long ago. Two of the major employers in the Baltimore City area are Johns Hopkins University and the University of Maryland, and I have the privilege of sitting on one of the boards, and the conversation in these two major employers was, what are we doing to be more active as well? So I think it's a big societal concern for our profession as a whole. I believe as a part of our educational programs, we need to be providing a basis and foundation for this. And then there's increasingly more data that's coming out. This income inequality, it used to be, and I'm oversimplifying, but by some, just viewed as a problem in the economic sphere. It has spillover effects to health and healthcare, so you can't look at it as a separate entity. But I believe much more needs and will be a path of our sort of a part of our future direction as interprofessional in particular.
Okay, so one more question. Go ahead, Tracy.
Good afternoon. I'm Tracy Snedden, a postdoctoral fellow here at the College of Nursing, School of Nursing. And like you, I'm a fellow buff from the University of Colorado. So cheers. My question today, Dr. Trautman, I thank you for your positive and optimistic presentation. My concern as we sit here amidst multiple generations is one that links to media and the public image of nursing. It was some years back that Johnson & Johnson did a very nice national campaign to try to improve the image of nursing, and I think there was some progress gained. But thanks to our existing television shows, virtual reality, whatever you want to call it, we continue to be damaged by what the public sees through media. And I just wonder what your thoughts are there, because despite our contributions to science, clinical practice, and leadership, we still suffer from that.
Yes, so very good point. There's a lot I could say about my displeasure with the media collectively, and most certainly some of what has happened with respect to the profession. I think, again, this is the building relationships, so building opportunities to interact with media more proactively, I believe is one area that's helpful. I believe our immediate and swift response when then there is an inaccurate portrayal has been stunningly effective. With Twitter and social media now, the stethoscope, the Miss America issue not so long ago, the nursing community rallied immediately from across all spectrums, and no one owned it, we all owned it, and that our voices were heard. Now, I would like to be where I think you are, is where our reaction isn't as important as our proactive steps. I think the media is a huge challenge, and we no longer, and a lot of, not just about nursing, the media, some argue maybe it never did. I thought it did when I was growing up, but the media has a bias. It depends on which station, which channel, which newspaper you pick up. It is not unbiased. So our job as a profession is to continuously get ourselves out front and present with media, and again, when they misstep, we have got to be immediately on it. There are more nurses consulting for some of the health programs, not enough, and clearly they're not paying attention to some of the consultation, but I think that that's another opportunity. And I think that there are some good examples. There was, I'm blanking on her name, but there's a nurse who was a journalist and was in the media. I'm so sorry, I can't remember her name. I'll send it back. But she published a book about nursing and what we needed to do. And the one point I would like to make is, even though some of what's said is unfair and not represented, we own a part of this, whether it's right or wrong, in that our responsibility to educate others, to not be worn down, to do our best, rest our heads on the back of another when we feel completely vulnerable and perhaps beat up by some of what's there, and then see when there are these highlights. You mentioned the Johnson & Johnson campaign, and that was wonderful. The nurse anesthetist did a fabulous commercial not so long ago, invested quite a great deal of money, but really changed some public opinion about the contribution of nurse anesthetists. And those are just some of the examples, but we need to do more of that.
Okay, I was wrong. We have one more question, and that's from
Oh,
Dean
yes,
Emerita
of course.
Littlefield.
Thank you for your presentation and for your very optimistic attitude. We need more people today to do that. My question relates to interdisciplinary education. One of the most satisfying things I did as a dean was teach an interdisciplinary course with physicians, pharmacists, and health policy students. In fact, the Learning Center, Interdisciplinary Learning Center, was created because we thought it would move forward. What kind of things are you doing in AACN to encourage? This is a very complicated thing to do, as you say, schedules, levels of education, et cetera. Are you doing some specific things for interdisciplinary education?
Yes. So thank you. Well, to answer your Well, first to comment, I agree that our work is very important for all of us, but most certainly opportunity for AACN to continue to do more to advance interprofessional education and collaboration. I think that one of the activities the AACN is doing with our IPEC partners is recognizing that we need to bring in and do more with practice so that we're creating a congruent learning environment in academia, then we're seeing how we can build upon and support that in practice. That's one area. Some have suggested, we have not done it yet, but that AACN could provide a paper of guidance for our schools, sharing exemplars, and so that is a part of our work going forward. We don't have a drop date on that yet, but really sharing exemplars, because there are places where it's been extremely successful. I had recently been in a conference and someone was talking about how difficult it is to get innovation in academics, and I walked out of the lecture thinking, well, I'm done. Can't even think about how it just seems so daunting. And then I had the opportunity to meet a very inspirational leader who said, we've done it. You can do this. So learning from others is important. And so AACN is hoping to do more of being able to showcase what our schools have done. Some of you may have seen, and while it might not seem big as a part of our information curation, we used to send out a weekly electronic newsletter. And it had chock full of good information. It was just a long laundry list. I hope you've had a chance to see our most recent. It's called AACN Newswatch. In there we try to highlight some exemplars, so IPE as well as other exemplars. Plus we provide some information. We provided a summary of the report from the Chronicle of Higher Education. We're trying to make it easier for people to get information. We went from 1,000 hits on that weekly newsletter to 11,000 hits. And I said it wasn't all me or my mom or my family looking at it. But so if we format information differently too, it helps get it out there and make it more meaningful. And then we've talked about having some convenings. AACN hosted for the first time this past July, and it was a wonderful success. We hosted a Thought Leaders Assembly. It was modeled with permission after Research America, and it was focused on the changes in higher education and technology. But we've talked about hosting one with respect to interprofessional education and practice. Again, not one approach that's going to reach the entire universe, but between published papers, opportunities for convening, sharing exemplars, those are some of the ways that we're hoping to help lead. Thank you.
Hey, we have a reception set up for all of you. Please feel free to go into Kern Commons and continue this networking and continue this conversation. You're all welcome. And help me thank Dr. Trautman for this great stuff.
Thank you. Thank you very much.